Welcome everyone. Thanks very much for joining us today. I'm going to be briefly talking about food sensitivity in the context of some of the myths that fly around. Now, when we talk about food sensitivity, we always feel as though we're up against quite a tough crowd because in our training and in some of the colleges, it's very much poo-pooed as a tool. So hopefully by the end of this, we can convince you otherwise. If you are indeed skeptical, you may be a believer like us. So today we're just going to cover really just a bit about food reactions, immune complexes. We're going to go through some of the common myths and look at the way that you can actually work with a fit test. We've also got a massive announcement. It's not just a big announcement, it's a massive announcement. And as always, we've got a cheeky special offer at the end for you as well. Now, as I said, please do ask questions as you go. And there's no such thing as a daft question. Please just fire away. Emily might be able to help you in the chat there, or some of the other people in the group, because I can see that Kelly's here and Tash is here as well. And this is the team. You may recognise some of us. I'm Charlotte Hunter, so I'm head of KBMO in the UK, and I've got a fabulous team, as you can see there. So hopefully we'll meet some of you at events, or certainly we'll speak to you on the phone. Claire does a lot of our practitioner support. So Claire's not on the call today, but she's often the person that you'll speak to go through your results. And the reason I wanted to do the talk today around myth busting, I mean, really it's a way for me to introduce the test as well, but the idea of myth busting really came from what I said earlier, that it's quite a challenge often to convince people that food sensitivity testing is in fact a really good tool for you. But we've had a lot of conversations recently about or around practitioner education. And very often there's this need for more and more and more information and wanting to learn more and more. But actually, as practitioners, you already know absolutely loads. So how can you apply that knowledge and use tests more effectively in practice to improve your client and patient outcomes, but also to be more profitable, to be more successful, to drive your business itself? So that was really the rationale behind this, from those two sides. One, well, food sensitivity testing can be useful in practice, but also how do you use it to be more effective as a practitioner? And I think when it comes to food reactions in general, it's a very, very complex landscape, I think. And this particular report found that 30% of adults report some type of adverse food reaction, meaning that they had illness or some kind of difficulty when eating a particular food. And when this was investigated further, it was found that around 6% of the adult population have a clinically confirmed allergy, which is about 2.4 million adults, that's a lot, isn't it? So yes, we have particular allergies, so largely IgE driven, but also we've got this huge section of the population, around 30% who have difficulties with food. And I'm sure that doesn't come as any surprise to you in your own practices. And what we'll see a much higher percentage because people are coming to us with problems. And I would estimate off the top of my head, probably 3/4 of the people that I see will have issues with some kind of food. And, I'd be interested to know what you see in your own practices as well. But in relation to food sensitivities, it's a bit of a minefield. And as I said, a lot of practitioners are really anti-food sensitivity testing. So these are just some of the things that I hear people saying. So they're unreliable, they're inaccurate. They want their clients to eat more, not less. The tests are a waste of money. Why do food sensitivity tests when you can do an elimination diet? And often claiming that that's the gold standard for supporting clients and patients with problems with food. But if you've done an elimination diet, you know how absolutely wretched that is. They're claimed not to be scientific. They only measure recent consumption. And there's a whole list of objections against food sensitivity testing. And perhaps, you're listening to this morning thinking, well, yeah, I agree with some of that. And honestly, yeah, I think all of those points are valid. However, it's the type of food sensitivity test is important just as much as, thinking about it in this umbrella sense, just, general food reactions. we have a very specific test. But I think in some cases, I would agree with a lot of these points. And, you know, you're perhaps thinking other things, you know, so if you do have any thoughts, please do share them in the chat. And one of the issues we think about is, well, why would you even want to test food sensitivities in the first place? Well, it could apply to anything, couldn't it? You know, we would think classically around digestive and skin issues, and, you know, sort of bloating, constipation, you know, various, sorry, just bear with me a second, I'm just letting someone in the room. And if you can just make sure that you're on mute as well, that'd be great, just so we don't get any feedback or barking dogs or any of the distractions. But really, think about food sensitivities. They cover a really wide range of conditions, you know, all the way from weight loss, thyroid issues, up to brain fog, fatigue, and migraines. So it does have many implications, I think, for practice. And I think this is a really great quote that sums things up. Now, this is from Dr. Joel Evans, as some of you will know from your IFM training if you've done that. And he did work with KBMO a few years ago. And he said the immune complexes and inflammation associated with foods are an underlying problem for all the conditions I see daily. And I think that's a fair point, isn't it? And based on the types of clients that you see and the conditions they're presenting with, it's feasible, isn't it, to say, well, actually, this inflammation and related to food is possibly a driver in a lot of these things. Obviously, in the wider context of other issues, but I think it's a really valid point. And just going back to what we were saying about food reactions, it's a really complicated landscape. I think very often, certainly in the nutrition field, which I'm a nutritional therapist, in my area, I think there is an oversimplification of food reactions. We tend to think of it as simply IgG or IgE, and then there's sort of nothing in between. But really, it's a whole spectrum of different reactions. And this is quite an interesting paper. I'll just put the reference there if you want to have a look at it. But it does break this all down, and it is far from simplistic. And for the medics in our audience as well, you know, even within IgE, we've got various different categories as well. So it's certainly a complex field, and to say that food sensitivities, food intolerances, food reactions, and all of the various classifications to oversimplify, I think, is quite short-sighted. But really, if we sort of pull that all back into, I suppose, a more workable definition, we really look at food reactions in three broad areas, certainly in, I think, the functional medicine side of things. So firstly, we have allergy, which is usually an IgE-mediated food allergy. It's immediate, it's reproducible, and it's potentially life-threatening. The FIT test and food sensitivity testing has absolutely no place in this part of a food reaction. A food intolerance is non-immune. So examples would include lactase deficiency, or perhaps FODMAP, malabsorption, things like that. Food sensitivity is delayed. It's often multi-symptom, and it may involve IgG immune complexes and complement activation. And this is the clinical space where FIT is relevant. But really, the clinical takeaway from this slide is that FIT is absolutely not appropriate for diagnosing allergy, but it can support non-IgE presentations. And in some cases, there can be sort of an overlap between food intolerances and food sensitivity. So in the case of histamine as well. So it's not completely separate. And then we have our mighty immune system. And I'm absolutely not going to go into this in any detail. But really, the immune system provides three levels of defense against disease-causing organisms. So we have our barriers. So that's preventing entry. So it could be skin, mucous membranes, stomach acid, digestive enzymes, our gut microbiota. We've also got innate immunity, which is our general defense. So our white blood cells, there to engulf and destroy our invaders and damaged cell, etc. And then the adaptive immunity. So please have a look at that in a bit more detail if you're interested, but it's just to give some background to what we're actually using the test for. And really, we're looking at that innate and adaptive immunity together, but then we're also looking at the barriers as well as part of our test. But we'll come back to that. So the immune complexes that we're actually testing in the FIT test is really illustrated here. Again, I'm dumbing this down quite significantly, but it's just to give you an overview. So when food antigens meet specific IgG, immune complexes can form. This can activate the classical complement pathway, producing fragments like C3d. C3d interacts with CRT on B cells and other immune cells, which amplifies immune signaling. And this is why the FIT test measures IgG 1 through to 4 and C3d complement. So IgG alone may represent tolerance, but the IgG plus the complement activation is much more likely to be seen linked to inflammation. And if you look at the diagram and just follow those little blue triangles, this is basically what I'm saying, is that they're going to pass through the lumen, it's going to travel through, we're going to activate T cells, B cells, we've got immune complexes, and as I said, we've got the complement activation, which is C3d. And the C3d is then can move further down that pathway where we get much, much more inflammatory compounds. But the real, I suppose, the key points is the C3d and also the IgG as well down here. Okay. And this is the test. So some of you may be familiar with this. I do recognise a few names, and I know that you do order the test. So thank you for supporting us, and hope it's useful in your practice. It's a finger stick test. So dry blood spot, 5 drops of blood on the little card, and then you send it back to the lab. Really easy at-home test. Now you can do a blood draw over in the US, but we don't offer that here in the UK. We only do the dry blood spot. And the test comes in 3 different versions. We have the FIT22, which measures 22 foods and is represented by these foods in the yellow box. We also measure 132 foods, which is the yellow and the green joined together, and also the FIT176, which includes everything that you can see on the page. So, as I said, it uses finger prick testing, and the reports are a traffic light system, so it's very easy for your clients and patients to follow. And then also have the gut barrier panel, which is included in the 132, the 176, and also now the 22, which I've missed off this slide. But if you look at the foods, it may not be as long as some of the tests you might have seen for food sensitivities, where they're running 400, 500 different foods. The reality is our clients are not eating that much variety. So what we've done with the FIT test is really try to include real world foods, and that does include raw and cooked. And this is what the report looks like. So really simple. So you can see which foods are elevated, and you get a nice summary as well. So as I said, it's easy to read, it's color coded, your clients can understand it, it's easy to interpret, it makes you more efficient in your practice, and it's easy to compare one report to another. So I suppose that the benefit for you is that you don't need to spend hours interpreting, you don't have to wait for weeks and weeks to get a support call to find out what it all means, and you can get your results and you can just run with them straight away. We've also got some compliance tools to support your clients. So there's a mobile app, and we also have a lovely practitioner's guide, which we can share with you. Now, if you don't have this already, we can make sure that you do get a copy, but this pretty much tells you everything you need to know about the FIT test. The other thing that we do to help you is we work with a number of companies who have specific plans that they use to support gut barrier dysfunction and to improve tolerance as well. So these are just some of the companies we work with, and we can share information with you. So now I've just given you a very, very brief overview of the test. I thought now we could just have a look at some of those myths in a bit more detail. So the first test, I think, is probably the obvious one, isn't it? And it's probably the biggest misconception. I think many patients, but also practitioners, think that IgG means allergy. And I think what that means is that IgG is almost being misused, or rather misinterpreted, as an allergy test. And I'm sure some of you can think of clients of yours who did a food sensitivity test 10 years ago and is still avoiding that food and tells everyone they have an allergy. But the truth is that IgG usually reflects exposure or tolerance. It's absolutely not a marker of allergy. And there are numerous professional bodies out there that uniformly recommend that IgG and IgG4 testing alone, and I say alone, should not be used to diagnose food allergy or intolerance due to lack of correlation and potential for misinterpretation. Now, just remember that means IgG alone. The FIT test isn't IgG alone. However, the FIT test, which includes IgG and complement, absolutely is not suitable for diagnosing allergy. So we never use the FIT test for any kind of suspected allergy, anaphylaxis, or IgE type symptoms. It can only be used for those IgG symptoms or patterns after red flags have been excluded and after that person has consulted with a medical clinician. Because as I said, there's a lot of grey areas between food reactions. It's absolutely, not as simple as IgG versus IgE. And the other one is no evidence. Apparently IgG has absolutely no evidence and should not be used in clinical practice at all. And you'll find some of the references I've mentioned here on the next slide. They're really just a selection of some papers that are widely available. I'm not going to go through in any detail. It's just to, give you a taster, really. And yes, if you were to examine every single paper individually, you would have to do a complete appraisal, look at some of the data, the trials that are being used in reviews, the numbers, the controls. I mean, there's so much stuff that you could pull apart, but I'm really just looking at a top level here. So, for example, there was a trial in gut in 2004, which showed IgG elimination improved global IBS symptoms versus control. There was an RCT published in Gastroenterology in 2025, which confirmed higher responder rates for abdominal pain in IBS on IgG exclusion diets. In migraines, there was a double-blind RCT in 2010 and 2011, which also showed reduced attack frequency with IgG-guided diets. And in 2021, there was an open label study which found that IgG-guided elimination rotation diets outperformed low FODMAP diets for IBS. So again, just a taster, but there is plenty of evidence out there if you have a good look around. And I would say the evidence is strongest for IBS and migraine studies, which interestingly, I think around migraine, I find really interesting. Not only am I a migraine sufferer, but I work exclusively with menopausal women, and I work with a lot of them who have struggled with migraines. And it's always put down to menopause, but generally there's something else going on prior to their menopause, and possibly a history of migraines already, or headaches, certainly. So it's a really interesting area, and something that we do get a lot of really positive feedback around. Also, I think anecdotally, skin is a good one. Again, I haven't quoted anything for skin, but we're seeing a lot of our doctors who work with rosacea, also just unexplained skin conditions that haven't responded to other treatments. We have seen some changes in that. So yeah, it's an exciting area, I think. And there's some of the studies that I mentioned. We also have some small-scale clinical studies that we've done ourselves. Firstly, we have inter-laboratory reproducibility. So we've checked the accuracy of our testing across independent labs in China, India, and also in the US. And you'll see, from that this includes a fit test, the gut barrier test, and this robust reproducibility is under varying lab settings, samples, reagent shipment conditions, sample stability. There's a great long list, but it is an incredibly accurate test on that basis. And we also have our own clinical studies. And yes, they're small scale, but they have showed improvements really across most of the areas that we tested. Again, particularly IBS. So if you want to look into that a bit more detail, please do. And if you want access to any of this information, we can share that with you as well. But I'm not going to read the slide out because it's incredibly boring for you. As interesting as it is to me, I won't just read out the numbers. But I think the big one for us was really the IBS test that we did. It was really, really interesting and we had great outcomes as well. Oops, hang on. So another myth, false positives. So this is probably, I would say, the biggest hurdle. And this idea that food sensitivity tests produce a lot of false positives. And I think it's worth remembering that not all IgG panels are equivalent. They differ in antigens, libraries, subclass measurements, their chemistry. There's a great long list. So not all labs are particularly good quality, I suppose. I'm trying to be polite. But the FIT test is unique because it's not just measuring the IgG. And I know I sound like a broken record, but it's measuring the IgG plus the C3d immune complexes. And the rationale is that this may highlight foods where complement is actively engaged, which is making results more clinically relevant. And by doing this, we help reduce the likelihood of false positives that occur with IgG-only testing. Now, I remember years ago where I used to do food sensitivities with a well-known company, not mention any names. I would order the tests because I was told it was a good thing to do at the time. I mean, bear in mind, I've been in practice quite a long time. So it was one of the few tests that we did, alongside adrenal stress tests. And we used to do candida tests where you just used to spit into a little tube and send it to the lab. So things have definitely moved on since then. But sending the IgG tests in, they would come back and there would just be lists and lists of foods that people couldn't eat. Alfalfa was always top of the list. I think everyone I tested reacted to alfalfa. But it didn't make sense. You can't ask your client to avoid, 50 foods. I sound like I'm exaggerating. I'm really not. Some people came back with huge numbers of foods. And at the time, yes, I worked with what I had and assumed there was a degree of gut permeability, and we did lots of gut support, but there wasn't the same understanding, I think, around IgG and this combination with C3d. And the test we run allows for enhanced sensitivity. And this is just a diagram of basically what we're measuring. So instead of that single signal, which you find in most conventional IgG tests, we're looking at two signals. So looking at the C3d, but also the IgG. And like many labs that are doing food sensitivity testing, we use ELISA. Oops, sorry, just gone back one there. So another myth, increased restriction. And this really, I think, continues from what I've just been saying about the false positives. I think critics of food sensitivity testing seem to worry that elimination diets are unsafe or they're overly restrictive. But with FIT, we use short, targeted elimination. So it may be as little as, say, 8 weeks, or 6 to 8 weeks even, which will be guided by the test. Obviously, that depends on the person, the number of food sensitivities that are triggered, and also the status of their gut barrier panel, because we have to look at the context. It's not just looking at the numbers to guide what we're doing. But however long that elimination is, which is targeted, and remember, with the combination of IgG and C3D, we're not going to get lists and lists and lists of food. You may have some people, it may be 3 or 4 or less, others it may be 10, 12. But there's always some context to those results. So this period of elimination is always followed by a structured re-challenge. So we're able to reduce as many foods as possible. Excuse me. And rotation strategies can also be really helpful to avoid long-term restriction and involving yourselves, nutritional support to make sure that if they are avoiding large food groups, that they're replacing those foods and they're filling any nutritional gaps. And just note here really about why isolated IgG testing is problematic. And really, the 3 main points. One is IgG antibodies are found in healthy adults, so is likely to reflect exposure. So in other words, an IgG test is like a what's your favorite food test. And I see this time and time again. Secondly, we have a high rate of false positives with IgG only tests. And thirdly, it can lead to unnecessary dietary restrictions. And I think we've talked about all of these, haven't we, in some ways. We've gone through our myths. And we also know that the current diagnostic guidelines from leading allergy and immunology organisations discourage routine use of IgG testing, and that's for food allergies and food intolerances, highlighting that the antibodies might indicate exposure or underlying inflammation rather than actual pathogenic mechanisms. But I think that's quite an interesting idea, because we're all in the business of inflammation, aren't we? That's what we do as nutritionists, functional medicine doctors, and other functional clinicians. We're interested in inflammation. So actually, if IgG testing shows inflammation, that's a good thing, isn't it? However, I would agree that we do need more well-controlled, large-scale studies to clearly define the clinical relevance of food-specific IgG responses, and also, I think, alongside the what we know about C3D complement as well. Now, at KBMO, we have the benefit of seeing IgG alongside complement, so we are able to interpret the findings within the broader context of each person's clinical presentation. And I think that's the important bit, isn't it? So our 5th myth, I promise you there's only 6 myths, so I'm not going to keep going. This is a really interesting one as well, this absence of clinical context. People say they don't want to use it because it's just abstract information. And I think, to some degree that's perhaps valid. IgG can reflect exposure or tolerance. And without context, we're likely to create over-restriction. Maybe, frightening our clients into thinking they're allergic to something. But then I take you back to what I said at the beginning. Think about those patients you have who did an IgG test 10 years ago and are still avoiding the foods, but still have bad guts. What is that telling you? And I think that is someone who has perhaps done a food sensitivity test, hasn't had the right support, has ordered it online, and is now still avoiding that food. And I think KBMO do a really good job of addressing this issue by integrating the gut barrier panel alongside the food reactivity section of the test. And this is the gut barrier is part of the FIT 176, 132, and now in the 22 as well. And it measures 4 markers. So we've got Candida is the top one. So this reflects, or rather the Candida antibodies that we're measuring flag fungal dysbiosis, which of course can perpetuate immune activation and gut symptoms. We've then got zonulin, which reflects the regulation of the tight junctions. So if it's high, we suspect increased intestinal permeability or leaky gut. Occludin antibodies indicate structural injury to the tight junctions, which also suggests barrier breakdown or certainly a compromised barrier. And probably most importantly, we have LPS. So LPS antibodies show gram-negative bacteria translocation, which is a marker of endotoxin exposure that links directly to the systemic inflammation that we're potentially seeing. So this means we're not just looking at a list of foods, we're assessing the underlying environment, and if barrier dysfunction is present, our plan isn't just elimination, it's also gut repair and microbial balancing. And I think that's really what moves the FIT from being a static IgG test to something that's to a clinically relevant panel, and a really great tool as well. So I'm just checking the chat, just looking a bit distracted there. Susan, can you expand on the Candida marker a bit more, please? So I think we have got I think we did a webinar on Candida a while back, so we can certainly share that with you. But as I said, we're measuring Candida antibodies. And of course, yeah, that's not necessarily just restricted to the gut. And of course, what we have to do is, and I've said a few times now, it's thinking about the clinical context as well. In some clients, if you have your gut barrier panel and it's bright red, they've got multiple food sensitivities, you might want to do a stool test in conjunction just to bring the two together and really find out what's going on, especially if someone's clinical context is severe as well. Perhaps they've got, I don't know, really severe IBS symptoms, or they have a history of inflammatory bowel disease. There could be lots of other things going on. Most of the time, a FIT test will give you enough information to support that client. But we do have these clients in particular who are in quite a bad way, and looking at the two together can be really useful. We have a session coming up in a few weeks where we're going to look at a FIT test combined with a stool test. So that might be an interesting one for you to join as well. So this is really what the gut barrier looks like. So the panel, as I said, it has those markers that we've just briefly mentioned. And we look at IgA 1 to 2. So that's just looking at the barriers. And then we're looking at the IgG and the C3d. So the innate and the adaptive immune system as well. So this really gives great context to the FIT 176 or 132, whichever one you're doing, rather than just looking at the IgG food sensitivities in isolation. We've just got a much more rounded perspective. And the last myth is really, and we've sort of touched upon this as well, but once you react to a food, you're stuck with that sensitivity and you're going to have to avoid it forever. And that's just not true for non-IgE sensitivities. So unlike IgE, which are often permanent and carry anaphylaxis risk, the IgG and C3d food sensitivities reflect an immune dynamic that can change. So that means it's not static, it will change over time. And research and clinical experience also show that after a period of targeted elimination, especially if you address gut barrier dysfunction, reactivity can reduce over time. And when we repeat the FIT, maybe after 3 to 6 months, again, this will very much depend on someone's gut barrier results and their food sensitivity results. Many foods will show at a lower antibody level, and you can see that progression and improvement. And I think that's why having a structured rechallenge is really important. The goal is not to permanently restrict someone, but to restore tolerance and maximize their dietary diversity. So we don't want someone avoiding dairy forever. We don't want someone avoiding, never being able to eat, some of their favorite foods ever again. It's about supporting their gut barrier and supporting their tolerance. because, you know, people demonize foods. You know, it's not the food's fault, it's your gut's fault. That's why, you know, that's where the problem is. And I think it's very easy to blame the foods, but actually I think it's about going back to that person, looking at their context, looking at their results and go, well, how can we improve things so that you're not avoiding all these foods or potentially reacting foods? So I suppose in that sense, the fit isn't about, I suppose, building a smaller and smaller diet with permanent food reactions and restricting that person's food. It's about creating, I suppose, pathways back to food freedom. That sounds a bit cheesy, doesn't it? But I think that's essentially what we're trying to do. We're trying to open people's diets up, open their choice, and just get eating more diversity and keeping that tolerance up. And where there are recurring reactions to some foods, it may be that they can eat those foods, but only on the basis that they rotate them. You know, they're not eating them every single day. So it's just a very, very brief summary of a case study. And really, it just illustrates why sensitivities are not necessarily permanent. On this lady's fit test, she showed a high reactivity to egg white, dairy, and almonds. Her gut panel showed elevated zonulin and LPS, which were clear signs that there was some permeability and potential bacterial translocation. So we combine a targeted elimination diet with gut barrier support, so things like zinc carnosine and prebiotic fibers. At 6 months, we repeated the fit test, which showed a reduced reactivity to egg white and dairy. She was also able to reintroduce them without any symptoms. Obviously, not all at the same time. It was a staged and staggered reintroduction. The only food that remained persistent was the almonds. I don't know why I wrote yeast. I'm so sorry. I must have had yeast on the brain for some reason. But it was really only the almonds that remained a persistent trigger. But she managed that with a rotation approach. You know, she could eat them now and then, but if she ate too many, her symptoms would come back. So this, again, demonstrates that the sensitivities are dynamic. With elimination, rechallenge, barrier repair, many of those foods can be tolerated again. So again, back to that goal of restoring diversity and not this lifelong restriction. And also by avoiding a food completely on the basis of an IgG-only test, you are potentially increasing the reaction to that food. And what we don't want is for people to shift class, you know, moving from Ig to potentially IgG. So it's not good to avoid those foods permanently. Now I thought that was my last myth. We have one more. So I'm just going to check the question. So Pam, you got a question about cross-reactivity, positive results to foods never eaten, for example, monk fruit. Yeah, I mean, I think cross-reactivity is really complicated. I don't think we've actually done a webinar on cross-reactivity for that very reason. So what can happen is some foods may show up in your report that have never been eaten, and it is to do with that cross-reactivity. Now, what we have in the practitioner guide is, well, it's lists and lists and lists of the foods and potential cross reactions. And if you have issues with cross reactivity, I think it's always best to have a chat with Claire, and she will help you figure it out. Very often, it depends case to case. Sorry, I mean, I think I always say to people, you know, if you ask a question in nutrition, the answer should always be it depends. Because there's never one answer to a question. And I think this is another it depends answer. But if you haven't got the practitioner guide, we'll send that to you because it does have all the information in about cross-reactivity. We are starting to put some information about that on our social media, just some little snippets about cross-reactivity. And we've created a new fact sheet on cross-reactivity. So just watch this space because we're going to be sending out more information on that as we go. And Ruth said, so the argument against the myth that it just shows the level of leaky gut and shows you're intolerant to foods you eat the most comes down to the C3D measurement as the game changer. Absolutely. Yeah. So it's giving you a more accurate picture of what's actually happening. And it's also giving you the context you need to make sense of the food sensitivities as well. So last myth, I promise this is the last one. So another criticism we hear all the time is that food sensitivity testing isn't scientific enough. And hopefully the KBMO fit test will challenge that view. There are other tests on the market that claim to be the most scientific way to test food sensitivities. Well, newsflash, they're using ELISA technology, the same as us. They're measuring raw and cooked, the same as us. They're largely IgG in one of their food sensitivity panels, and they cost a lot more money. You know, not just a few £100s, we're talking thousands. So I think the criticism that some of the other tests on the market aren't scientific enough, I don't really buy that. Now, firstly, our method is patented for detecting immune complexes. So this is not generic IgG testing, it's a unique validated approach. There's no smoke and mirrors, we tell you exactly how we test, but what we're measuring is that dual signal, not just one signal. So the fit tests IgG and C3d, which is a split product of complement activation, which we very, very briefly covered at the beginning. And that ties the results to inflammatory biology and not just exposure. The gut barrier panel is adding another layer of science with zonulin, occludin, candida, and LPS antibodies, which is giving you insights into why food sensitivities might be occurring in the first place. It's assessing the integrity of your gut barrier. KBMO is a certified FDA registered manufacturing facility and a CLIA high complexity lab, which means it meets rigorous diagnostic testing standards. You can't hide when you have these certifications. Also, the concept of IgG guided elimination, even without the C3d, still has some clinical backing. So yes, I've completely tried to destroy IgG only testing, but there's still a little bit in it. You're not going to get as much information. It's just really looking at one side of things, but overall there is a body of evidence. Our testing, so our inter-laboratory comparisons and also our own small-scale studies involving C3d have shown amazing results as well. The original test was created by Dr. Brent Dorval, who is an MIT superstar. We also have an exceptional R&D team as well. And the gut barrier panel was created in consultation with Fasano's team. So I think we're nailing it on the science part. And also Dr. Brent was the creator of the first rapid response HIV test. So he's quite a big deal. So I'd really say, far from being unscientific, I think FIT is really rooted in solid immunology, and it's carried out in a diagnostic lab with high standards and also published trials. So I think we're nailing it, as I said. Ruth asks, do you see tests in a year or so bringing up new intolerances, e.g. resolving original sensitivities but finding new ones? Why would that be? Can you become sensitive to a food that you weren't sensitive to before? Again, it depends, Ruth. Sometimes we do occasionally, but generally more sensitivities come up when the gut barrier hasn't been supported, hasn't been addressed. So they've avoided the food. They might have taken their supplements for a couple of months, but then they've sort of given up and just carried on avoiding the foods. Now, if you avoid the foods, it's not really helping anything, is it? You're just avoiding the foods to avoid the symptoms, but you're not dealing with the underlying issue. So very often new sensitivities will come up because the gut barrier isn't healthy enough. The gut hasn't been supported. You know, perhaps they're eating, a more restrictive diet. But there's bound to be 101 different reasons, and it will vary case to case, I think. So now we've whizzed through the myths. I think what we should be clear about is when not to use the FIT test, which might seem a bit odd when I'm trying to encourage you to use the FIT test, but really it's about pointing out some really important things. So it's not a test for IgE-mediated allergy or anaphylaxis risk. they require specialist IgG testing and workup by a specialist. And I think there are some tests that are available to us which do include IgE, but I don't think we should go there. I think it's beyond our remit and we're not qualified to deal with that. And I'm talking about non-medical clinicians and practitioners here. It's not suitable for a celiac diagnosis. That needs specific serology and biopsy. It's not, or it shouldn't be used in people with eating disorder risk. Because if you're using a fit test, it's potentially going to increase the elimination of foods and encourage, I suppose, restrictive behaviours. You could do the gut barrier test, but I wouldn't be using the food sensitivity part because you can buy the gut barrier as a standalone test. And the real clinical value of the fit test is really when it's used as part of an elimination re-challenge framework. And I think the final point I'd like to make is that it must always be interpreted with a broader clinical context in mind. It's not a standalone diagnosis, and it should be used as a tool to inform your practice. And as a summary, I've included really just a 6-step workflow that I recommend to make the fit test more clinically useful. So firstly, always pre-screen. Rule out red flags such as unexplained weight loss, history of inflammatory bowel disease, or colorectal cancer. Audio fit and with the gut barrier panel, certainly if you suspect permeability or dysbiosis or symptoms suggestive of that. Implement your elimination phase. It could be 6 to 8, but really depends on the context. And always focus on removing the highest reactivity foods first. And it's being about targeted, not restrictive, and also ensuring that nutritional adequacy is maintained as well. Think about a structured re-challenge. So reintroducing those foods one at a time, ideally every 3 to 4 days, and use symptom scoring tools. So for example, the IBS symptom severity score, or MIDAS for migraines, or whatever you want to use to measure how things are going for your client. Step 5 is rotation. So we want to avoid long-term restrictions and maintaining microbial diversity. And what we want to do is make sure that people are eating a varied diet. And repeat the fit selectively. Don't just retest automatically. But use it if symptoms are persisting, or sometimes as a motivational tool to show your client their improvements or how their immune reactivity is changing. But we should never just test for the sake of it. We should be testing with a goal in mind. Some people don't do the whole test again for financial reasons. Maybe they will run the Fit 176 and then we'll do the gut barrier 6 months later. And in that client, you might need to do the whole test again in another 6 months. So it takes a long time for the gut barrier to present those markers that suggest permeability. And it's going to take a long time to support that as well. So keep that in mind. So that's our run through of the myths. And we often do this as an introduction to KBMO, but I thought it's a new term. So let's shake things up a bit and look at the test from a slightly different angle. And it's about how you use the test in practice. Everyone can find out about the test. You can look at some of our videos, you can ask us questions, but I think it's important to think about how you use the test to improve your outcomes, but also improve your practices as well. Now, at the beginning, I said we had a massive announcement, a big announcement, which I decided should have been called a massive announcement. As of yesterday, we're now selling a test called the Hormone Insights test. So it's powered by the Advanced Urine Hormone Metabolites Test by ZRT. It measures 44 hormone-related markers. We have 13 estrogens, 8 androgens, diurnal cortisol, melatonin patterns, and also BPA, which is a really useful endocrine disruptor marker. We also have insights into metabolism and detoxification, so of estrogens, progesterones, androgens, cortisol, and melatonin. And it's actually one of the most detailed hormone metabolism tests available. This was the test that actually preceded the Dutch test. So the Dutch test was based on this test. So the person who set up Dutch used all the information from this to create the Dutch test. So it's I suppose you could call it the original Dutch test in many ways. The practitioner price is $249 and the patient price is around $299, but that would be entirely up to you. But what we wanted to do is just provide another at-home test that complements the FIT test and the gut barrier as well. And a lot of our practitioners do work with women. This can be used on men as well, but the gut barrier, the hormones, and the food sensitivities, it's a really nice combination to work with. Now, we have been a little bit cheeky with our images. I'm sure that wasn't lost on you. And as you know, or if you know me, I do a lot of work with the Dutch test. However, in recent months, I've switched over to ZRT because it just gives you the information, that need-to-know information. And if you're using, excuse me, if you're using tests like Life Code with their hormones and estrogen metabolism reports, it sits alongside that better because there's much more information around progesterone and androgens compared to the Dutch test. Also, what's interesting is that you get the diurnal cortisol, but you also get diurnal melatonin rather than just one marker. So you can see the two together across the day that you're testing. So if you'd like more information about that, please get in touch with us. Our email is ukoffice@kbmo.com, kbmodiagnostics.com. Emily, put the email in the chat. I've just totally confused everyone with the results. I haven't got a sample report today, but we are going to do a webinar next Tuesday where I'm going to do a very brief overview and just really introduce you to the test, why we've included it, why you might like to consider it. And we have a series of videos that have been recorded by Dr. Shania Sieber, who is going to go through the test. So an introduction, she's going to then talk about the different markers. And then the third one is really looking at a case study as well. So there will be resources around this, but it's really exciting. And I mean, I love hormones, so this is just brilliant. I'm so excited about this. And we're going to be sharing loads of information in the coming weeks. We're also going to have interpretation sessions, so you can come along and we'll talk about different cases, really, so that you're learning about the test, because I think it can be really difficult with some of these more comprehensive panels that you have to wait for your support call with the lab. We want to change that model to make it a much more of a collaborative space involving our practitioners. So we're excited to share that with you in the coming weeks, days and weeks. But if you do want more information, or you want to speak to me directly, we can sort that out, and I'll be happy to talk you through it. And I can tell you off the record things that I'm not allowed to say while I'm being recorded. So just to finish, I'd like to share this special offer with you and really just wrap up what we've talked about. So food sensitivities are not the same as allergies, and they aren't permanent. I think that's the big take home here. The KBMO test is not just another IgG panel. It's a multi-pathway assay measuring IgG 1 to 4 plus C3d. And then we now have the added context of the gut barrier panel. We've seen the evidence, so IBS, migraine, and now even multi-center RCTs showing that antibody-guided elimination can meaningfully improve your client symptoms. And I think most importantly, this isn't about restriction. Used properly, the FIT test is there to restore balance, to improve tolerance, reduce inflammation, and really give our clients their food freedom back. So this special offer is really an opportunity for you to put this into practice. Now, normally the FIT 176 is $300. And for anyone who attended the session today, you can buy a test for $180, and really just so you can experience the test. try it on yourself, try it on a client. But really, we want you to see how it can potentially transform your practice and also improve your client outcomes. So on that note, thank you very much for joining me and keeping an open mind to the science and myths around food sensitivity testing. I hope you all feel more confident around food sensitivities and hopefully introduce this, if you don't already, as a clinical tool to make your work easier and hopefully more effective. And Julie said, how do I redeem this? If you email UK office at kbmodiagnostics.com.
Charlotte,
Yeah.
sorry to jump in here at the end, but I have realised that I promised somebody we'd come back to their question and we haven't yet. And I couldn't answer it on the chat because my Wi-Fi dropped out at the very
Oh
moment we
no.
were talking about it. So could you just very quickly, sorry to take you right back to it, for the benefit of Marika, just reconfirm what you were saying about ELISA testing in regards to
Okay, so we use ELISA testing for our food sensitivity testing, which is, you know, a fairly standard approach for most labs that are doing this kind of work. So there are some labs out there that say that their testing is way, way more superior to the techniques that we use, but generally they all use the same. So there's a lot of smoke and mirrors around labs and lab work. Everyone likes to tell everyone else that their tests are rubbish. Me included. No, I'm joking. I'm joking. But yeah, I mean, if anyone has any questions, I know we've hit 11 o'clock. I'm quite amazed we've managed to get through all of that in an hour. But if you have any questions, I'm happy to hang around. And for anyone who's leaving, thanks very much for coming along. And please try out the test. And if you do want to know more about the hormone test, again, email UK office and we'll get back to you. It is on our website as well. I forgot to mention that. You can find it on the website now as well. Thank you.
Thank you. Thank you.
Thanks.
Thanks. Bye.
Bye.